I can hear you.
Test 1, 2, 3. Okay. Today I'm given the topic of a clinical chemistry examination for supporting diagnosis at clinic. Okay, so what is clinical chemistry? So at first, clinical chemistry is the area of chemistry that is generally concerned with analysis of body liquids like blood, urine, cerebrospinal fluid, peritoneal fluid, or even thoracic fluid for diagnostic and therapeutic purposes. So, veterinarians have been used the clinical chemistry and other laboratory tests within the microbiology, virology work, hematology to diagnose a disease, to monitor disease progression or respond towards the therapy. Okay, okay. Can we see the laboratory diagnosis where the clinical chemistry is a part of the laboratory diagnosis. So from here, together with the history, the clinical examination, and also the laboratory diagnosis, we can go to differential diagnosis and come up with diagnosis and later on for the treatment. Okay, next. So, so as a veterinarian in the future, you have responsibilities. The first one is to provide the appropriate sample for the laboratory analysis. And if possible, the sample must be fresh. If not fresh, so it must use a correct preservative. And then as a clinician, you have to provide a good quantity of the sample so that the laboratory people they can have to process and to diagnose. And then one more thing is we have to request an appropriate test. Okay, it's very important for clinicians to request appropriate test. We cannot miss any test so that we do not no need to do a resampling of the animal. Okay, that's so. What are the responsibilities of the laboratory? So later on, for the animal clinic, some of the animal clinic, they have their own clinic. I mean, they have their own blood machine, doing the urine analyzer. But some of the clinics, they need to submit the samples to the private laboratory or the government-based laboratory in order to do a diagnosis of the for the clinical community. So what are the responsibility of the laboratory? The first one is to process the sample, and then if possible, we must process the sample as shortest time as possible, as faster as possible, and the last one is to report the result. So the result must be accurate, so that it will be a beneficial benefit to the clinician. Okay, Okay. So what are the factors that ensure good and interpretable result? Okay, for us to ensure that the result is good and interpretable, we have the clinical information of the history, the physical examination findings must be available, and then the samples must be collected appropriately. So the correct preservative must be used, and then if we have to ensure that when we transport the transfer must be in the good condition, it must be fresh, and then the testing of a sample, so using a suitable technique, adequate equipment, appropriate condition, well controlled, good recording, and also reporting. Okay, next. So what are the limitations of the clinical pathology test that included the clinical chemistry? So one thing that we have to take note that the life is not analyzable. And then number two, for the testing of the glucose, the best sample is by using, we have to collect using the sodium chloride anticoagulated blood. And then for the hematology, the blood cannot counted for 24 hours, even if it's a well preserved. So that means we have to process for hematology less than 24 hours, and some of the tests are very expensive and it's not economical at all. Some of the tests like hormone tests, the acute phase protein, so it's a bit expensive. And that most tests are not diagnostic if you don't know the reference value. That's why when we want to interpret the result, we must have the reference value. The reference value we can refer to the internet, we can refer to the journal, to the references. So that from the reference values, we can know either the parameters are normal. If the parameters are abnormal, either very high or very low. And then a test or set of tests are often not diagnostic if done only once. Okay, that's why we have to do a sequential analysis. For example, if you want to diagnose a kidney disease or liver disease, then we have to do a sequential analysis. We have to do repeated sampling so that we can get a better image, a clear image of the progression of the disease. And one important limitation, which is very, very important for us to take note that the most tests are not a particular disease, but it only indicated the system affected. Like for example, liver parameters, high of the alanine transaminase, alkaline phosphatase is not specific to the particular liver disease, but it only indicates there is some abnormalities. The liver system is affected. Okay, next. Okay, so interpretation of the clinical pathology finding. When we have the result, we have to compare with the reference range. And from here, we can see there will be a difference. If you find a difference in terms of the result, when you compare, okay, Assalamualaikum. Saya nak tanya, saya punya suara clear ke ataupun terputus-putus? Macam mana? Can I continue?
Masih
So I need Hello, Assalamualaikum.
More clear than now.
Okay, now I'll talk about a sample collection. Okay, for the sample collection, so we know that for the chemical testing is usually performed on serum of blood sample. And so in order to optimize the result of the chemical testing, the serum of plasma it should be separated from that as soon as possible after we collect it so that we can minimize the artifact that occur in the test. Okay, the blood tube. And then chemical testing is always related. We can collect the sample by using the blood tube. And then I believe that you have learned, you have know about this various type of the blood tube, like serum blood tube, the heparinase plasma, the EDTA plasma, and the citrate plasma, and also the serum aspirated tube. So the best blood tube in order for us to do a clinical chemistry is the serum blood tube. So this serum blood tube is preferred compared to plasma for the electrophoresis and also testing of the all chemistry analytes except for the potassium because but the potassium will be released more in the serum compared to the plasma during the clotting process. And then for the heparinase plasma, so it's the preferred anticoagulant for the chemical testing so compared to EDTA. And then for the EDTA plasma, it can be used for testing of the most analytes, with the exception of any enzyme and also electrolyte like potassium, iron salts, and minerals like calcium and magnesium. As we know that the EDTA it will chelate the calcium, so there will be some impact on the calcium reading. And then the citrate plasma, so we use this citrate plasma mostly for the clotting process. So it's not generally it's not used this one for the chemistry testing. And then for the serum separated tube, so it contains a gel. And it's until this gel it will have to separate the clotted cells from the serum. So we can use the serum separated tube especially for the large animal practice, which is it takes a time for the blood to clot and then okay next. Okay, now we talk about the storage artifacts. So we know that if we don't separate the blood cells from the serum or the plasma, it will may result in the false changes in the chemistry result. So these changes we can minimize it by doing the cold storage, including the refrigerated. So we have to ship on the ice pack, and as there are some kind of the storage artifacts that we can observe or we can see, like hypoglycemia, because the cell, the blood cells in the blood cells, so they can consume, they can eat, they can feed the glucose that will lead to the hypoglycemia. So this is a false hypoglycemia. And then in the species like horse and sheep, they have a high potassium in their red blood cell. So this will lead to the hyperkalemia. And then one more thing, the common artifact that related with the storage is the hemolysis. So this hemolysis it can affect many different types of results in different. Okay, next. Okay. So clinical chemistry can be used in order for us to evaluate the kidney function, the liver function, the digestive system, the plasma and serum protein, for us to evaluate the muscle, the pancreas, the glucose metabolism, the endocrine glands, like pituitary glands, the parathyroid glands, and also the adrenal gland, and also for us to evaluate the electrolytes such as potassium, potassium, magnesium, and all. So today, I try my best to discuss some of the major clinical chemistry tests that routinely available in the most of the laboratories. Okay, next. Okay, the first one is the kidney function test. So what is this kidney function test? Because we want to evaluate the kidney and we want to detect any significant impairment in the renal function. So we know that one of the main function of the kidney is for the excretion of the waste product, for the absorption of the water and also sodium. So the kidney also responsible for the production of the erythropoietin hormone, and there are many more functions of the kidney. So by doing the kidney function test, we can know is it the kidney is a well function or not well function. And next one, we can do assessment of a renal function for diagnosis of specific diseases. And as we know that the kidney function, when there's kidney having a problem, so it will impair the kidney function. So there were two common diseases related to the kidney, like acute kidney disease and also chronic kidney disease. And what we there are a few things that we should consider when we perform the kidney function test. Number one, the kidney can compensate 50-70% of the nephrons before we can observe the serum biochemical changes. And number two, test should be performed on a number of samples per time. That means we have to collect few times of the blood sample in order for us to determine the progression of the disease, the prognosis of the disease. And one more thing to remember that there are certain metabolites be absorbed by the tubules, while others metabolites cannot be absorbed by the tubules. Okay. Okay. Next one is I'm going to talk about the tests that are used in the assessment of the renal function. These are the routine tests. The first one is the blood urea nitrogen, BUN, the serum creatinine, urinalysis, and also serum electrolyte, such as sodium, chloride, potassium, potassium, and phosphate. And then there are also other tests, kidney function tests that can use to assess the kidney function, like the kidney enzyme. For example, the gamma GGT, the alkaline phosphatase, and also beta glucuronate. So next one. Okay, now we go to the first markers or test related for the kidney function, which is the blood urea nitrogen. So urea is basically a serum biochemical marker of nitrogenous waste retention by the kidney. So urea itself, it represents the end point of the protein metabolism. So during the process of the protein catabolism, the ammonia will be generated within the liver, and later two molecules of the ammonia it will combine together to form the urea. So there are factors that affecting the BUN. As I mentioned just now, the BUN is related with the protein catabolism. So protein catabolism related to the protein diet, when there's a tissue or muscle breakdown, when there's a protein synthesis, and then as we know that because of the urea is produced in the liver, so any condition of the liver, it will affect on the blood urea nitrogen. Okay. So there is one term related with the increase of the BUN and also creatinine, which is the azotemia. So what is azotemia? So azotemia refers to the accumulation of the nitrogenous waste in the blood. So what are these nitrogenous waste? So they are blood urea nitrogen and also creatinine. And then for the azotemia, there are three types of azotemia: pre-renal azotemia, renal azotemia, and also post-renal azotemia. Pre-renal azotemia, usually it will give a mild increase in urine. So that means when we check the blood result, we can see a slight increase of the blood urea nitrogen. So there are two main factors that can cause a slight increase in the blood urea nitrogen, which are increase of protein metabolism due to the intestinal hemorrhage. So why that's occur? Because as we know that the hemorrhage content the RBC, the hemorrhage content of the high protein. So this high protein, it will increase the BUN. And then the second one is circulatory disorder. As we know that when there is a circulatory disorder, there will be a reduced blood flow to the kidney. So a condition like hypovolemic shock, dehydration, so lack of the water in the body, and also cardiovascular disease due to the decrease of the cardiac output. So it will affect on the blood circulation to the kidney. Okay, next one is renal azotemia. So this renal azotemia, from the term itself, we know it's associated with function. So BUN will increase only when 70% of the members are affected. And then the renal azotemia, so it will come together with the clinical signs of uremia. So what is different between the azotemia and also uremia? So azotemia is increase of the BUN and creatinine, whereas the uremia is a refer to the azotemia with a clinical signs of the polysystemic sequence of the renal failure, like depression, vomiting, gastric ulcer, uremic encephalopathy, acidosis, and also hypotension. So renal azotemia, so we need to do a severe BUN determination. That means we have to apply a few times in order for us to help us to observe or to monitor the progression of the disease. And the last one, the third type of the azotemia is a post-renal azotemia. So from the word post-renal azotemia, we know it's related with the obstruction of the urinary tract. Like Like for example, it's obstructed by presence of the urolithiasis. Urolithiasis. Like for example, white, calcium phosphate, calcium carbonate, and etc. And so PUN, it will return to normal several days after release of the obstruction. So when we do a cystotomy, remove the urolith, remove the gallbladder stone, or we do the retrograde hydropulsion in order for us to establish the urethral patency. And ultimately, once we do, when we relieve the obstruction, there will be drop of the beer and also creatinine, so it will return to the normal value. Okay, next. Okay, next one is serum creatinine. So this is a second parameter related with the kidney function. So the creatinine actually is originated from a creatine, and this creatine is uh, the creatinine is originated from a creatine, and this creatine is mainly synthesized or formed in the liver from arginine, glycine, and also methionine. So when it leaves the liver, so it will enter the blood circulation, and this creatine it will be taken by the muscle, and then in muscle it serves as a high energy source, and the creatine it will added with the phosphate group to produce the phosphocreatine, and later on the composition of the phosphocreatine so will later produce the creatine. And then in terms of the excretion, the creatine is freely filtered through the glomerulus, and then some amount will secreted by a tubule, and creatine can be a useful index for the glomerular filtration type. And then one more thing that we have to take note that the serum creatine is not significantly affected by the diet. So it's not like the urea, UN, it UN related to the protein metabolism. The more the animal consume the meat, the protein diet base it will decrease but it's not happen for the serum creatine. And then one more thing that the small amounts of serum creatinine will be absorbed back to the tubule and will enter back to the circulation. Okay. Okay. Okay, next one is urine protein creatinine ratio. So this is we call it also as UP ratio. And the UPC is a test to measure how much protein lost through the kidney. And then it can correlate with the morbidity. So the higher the UPC, to the worse in terms of the prognosis. So the UPC is very important for us to evaluate for the proteinuria. So we can rule out the pre-renal and also the post-renal proteinuria by monitor the UPC ratio. And then if you look here, I mentioned here, the normal UPC is less than 0.5, but if we see the more than 1%, so it's clearly abnormal, and it indicates proteinuria, and also it indicates. And then right now, there's a one test, we call it as a SDMA, the symmetric dimethyl arginine. So this one is a type of the amino acid. This SDMA test is the early test. It's the early test for detect the kidney. Because if we rely on the serum in the creatinine, when the animal having a 70% of the damage of the kidney, it will it will produce the high quality level. Tetapi apabila UPC high, apabila when we use the UPC, when we use the SPMA as when the 25% of the kidney is damaged, automatically we can detect the presence of the SPMA. That's why in nowadays, in the small animal clinics, people rely on the use of the SPMA to detect the early contaminants. Okay, next one is a urinalysis. And there's a lot of the urinalysis. It can provide a wide variety of clinical information. The first one on individual, either it is damaged or it can be used to detect the structure and function of disorder. So as we know that the kidney have a thrombolysis, we have also a tubule, so we can diagnose the kidney disease. And then the second one is for the systemic disease that affecting of the kidney. So what that means? That means the kidney is somewhere else, but we can see the manifestation in the kidney. Like for example, diabetic mellitus, we see hyperglycemia, and then we can hyperglycemia, a high amount of glucose in the blood, and then we can see, we can check the glucose level in the urine. That's why we can observe, we can see the glucose here. And then urinalysis, if we maximize it, we can get a lot of information on the disease itself, its causes, and also the causes. And then in order for us to collect urine, it's very simple procedure. And then one more thing, urinalysis is a very rapid test. Yeah? Okay, then. Okay, these are some information or disease or disorder that are related with, that we can appreciate, we can diagnose through the changes in the urine. For example, in case of the kidney disease, there will be an abnormal in terms of the specific gravity. So we call it as isosphenoria. And then we can see a presence of the protein in the blood, proteinuria, presence of the starch, presence of the white blood cell, and also the presence of the erythrocyte. Okay. When for the bladder infection, the cystitis, inflammation of the urinary bladder, so there will be a proteinuria, presence of the epithelial cells, leukocytes, and also bacteria. And then in case of the liver disease, we can see changes in the disease. We might observe presence of the bilirubin, the urobilinogen, and also the bilirubin. And in case of the hemolysis, the blood parasite, the Escherichia bovis, the Escherichia canis, we can observe, we can check for the presence of the hemoglobin in the urine and also presence of the urobilinogen. As I mentioned just now, for the diabetic mellitus, so there will be a glucose here, presence of the glucose and also presence of the ketone in urine, and there will be high specific gravity because the glucose, so the higher the glucose, so it will decrease the specific gravity. And then in terms of acidosis, there will be a low in terms of the urine pH, alkalosis will be high in terms of the urine pH. And one more thing is for endoplasia of the urine tract. For example, the transitional cell carcinoma, the TCC, we might see exfoliated neoplastic cells, the presence of neoplastic cells in the urine, and there will also be a hematuria because the neoplastic cells, it will invade the blood vessel, so you will cause a hemorrhage. That's why you observe presence of the red blood cells. So routine tests in urinalysis, I believe that this one has been taught in the class by your lecturers. So this is like a revision, and then we can for urinalysis, so we can divide it into three examination. The first one is a physical examination. Number two is a chemical examination, and number three is a microscopic examination. So when we talk about physical examination, that means look the urine. So from the value of the urine, and then the color of the urine, either the normal color, either there will be a bright red, red brown, or dark red color of the urine, and then we can check on the turbidity, either high turbidity or low turbidity, and this turbidity is always associated or related with the presence of the cells in the urine. So when there's a more cell, crystal, cast, and regular cells in the urine, they will cause more the urine become very turbid. And then the specific gravity is the specific gravity is the ratio of density of urine to water, and then the specific gravity, so they are hyposphenuria, isosphenuria, and hyposphenuria. The next one is a chemical examination. We can check on the pH, the body, glucose, the ketone, urine, urogenogenic, and then microscopic examination, urine sample, we can centrifuge, then we can stain with the right stain, and then when we check on the microscope, we might see presence of the erythrocyte, the leukocyte, the epithelial cells, cast, crystal, or even fat. And then we may observe also microorganisms like bacteria, parasites, and also spermatozoa in the urine. Okay, for the chemical examination, this is routinely used in urinalysis. People usually they rely on the strip, the urine strip test. So urine strip test is a rapid, accurate, and quite efficient. So if it is conducted properly, a very sensitive and specific, and most important, the cost test, which is I think in the YouTube for the one test. I mean the price for the urine strip is only 1 ringgit. I don't know the price. Okay, that's one. Okay, next. Okay, the next one is the pH or hydrogen ion concentration. So we can rely on the urine strip, or we can use a pH meter or even a pH meter. But urine strip is joint. And then the pH is depend on the diet of the animals. The carnivores, so the carnivores mostly they have the acidic urine, but for the herbivores, for the ruminant animals, cattle, sheep, goat, they have the alkaline urine. So in order for us to check the pH, the urine must be fresh. And we have to alert that there are many conditions or factors that can contribute to the acidity and also the alkalinity of the urine. Like for example, the faulty diet will cause acidic urine, starvation, dehydration, diarrhea, diabetic acidosis, metabolic and respiratory acidosis, affect metabolism, and also acid producing bacteria. And same goes to the alkaline, like for the herbivore animals, so they easily have the alkaline urine. So can we move to the next slide? Okay, next one is a protein. So protein, put in your mind, the protein not the found in the urine. Because of what? The protein is too large. The protein itself is large to pass the glomerulus. Okay, so when we observe the protein in the urine, so it indicates a proteinuria. So in the kidney function, either glomerular damage or tubular damage. When there is a marked proteinuria, bila kita boleh nampak isi protein di dalam urine, selalunya Kalau kita nampak mild proteinuria is associated dengan gula abdomen and the body. And then in the slide, I show you by using a stick, urine stick, we can get result 1 plus, 2 plus, 3 plus, and 4 plus, and then we can approximate in terms of the value of the protein in the urine. Like for example, if this stick show a 4 plus protein, so it indicates more than 5 gram per liter of the protein in the urine. Next one. Okay, next one is the glucose. Yeah. Same thing with the protein. We cannot detect glucose in the normal urine. What happens is glucose, they have effect on the specific density of urine. Like 1 gram of the sugar, it will increase the specific gravity by 0.004 unit. That's why in case of a diabetic patient, in case of diabetic mellitus animals, there will be a high specific gravity because the sugar it may mask low specific gravity. So presence of the urine in the blood is the glucose urea. We might see in case of diabetic mellitus the stress. And when animals having the stress, there will be only a slight or mild increase of the glucose compared to the diabetic mellitus. And then when there's a pancreatic necrosis, and as we know that the pancreas produce the insulin hormone, that's why there will be a hyperglycemia in the blood, lead to the glucose urea. And then when the animal have an endotoxemia, and this endotoxemia lead to the pancreatitis, which is it can also lead to the pancreatic necrosis and so on. So there will be a glucose urea. And the last one, the drug therapy, you can use also the glucose urea. Okay, next. Okay, for the ketone bodies, there are 3 common types of the ketone bodies. Yeah? The acetoacetic acid, the acetone, and also alpha hydrobutyric acid. And then, which ketone bodies are mostly produced? Okay, the mostly produced ketone bodies is the hydrobutyric acid. Yeah? About 70% of the ketone bodies come from the hydrobutyric acid. But however, the urine sleep, we can detect is more sensitive to the acetoacetic acid compared to other type of the ketone bodies. And then these ketone bodies is related with the decrease of the carbohydrate available for the energy metabolism. That's why in case of a starvation, diabetic mellitus, excessive fat in the diet, ketosis, and also pregnancy toxemia, we will observe, see the presence of ketone bodies in the next. Next one is the bilirubin. Again, bilirubin we cannot find in the normal urine. And the bilirubin actually is a breakdown product of the hemoglobin. And then there are 2 types of the bilirubin, the conjugated one and also the unconjugated bilirubin. So the conjugated bilirubin, so we call the conjugated bilirubin because the bilirubin undergo the conjugation process in the liver. So one more thing is the conjugated bilirubin, they have a lower residual threshold compared to the bilirubin. And that's why, so that means the conjugated bilirubin, it cannot pass through the glomerulus easily compared to the bilirubin. So what happens is when when there is a high amount of concentration of bilirubin in the urine, that's why there will be changes in the urine color. We can see a dark yellow to brown and foamy urine color. So bilirubinuria is always seen in case of the hemolytic disease, which is this is the type of the pre-hepatic disease. For example, in case of the acute babesiosis caused by the Babesia bovis, Babesia canis, Babesia vigilina, and then hepatocellular disease. So this is a hepatic base, and also bile duct obstruction due to the cholestasis, and where we can see there's a blockage of the urine, or we also call it as the post-hepatic disease. Okay, next one. Okay, next one is the urobilinogen. So this urobilinogen also related with the hemoglobin breakdown. Hemoglobin breakdown. So this urobilinogen, so it forms in the intestine by bacteria reduction of the bilirubin. So how we interpret presence of the urobilinogen? So its presence indicates that the bile duct is affected, so that the bile can flow to the small intestine via the bile duct. And if it's absence of the urobilinogen, we can suggest there's some kind of the bile duct obstruction. And then decrease of the urobilinogen, there are some factors that can associated with the decreased urobilinogen. The first one, when the infant lack reducing intestinal bacteria. So when we use the oral antibiotics, so this antibiotic will suppress the intestinal flora, because we know that at the first point I already mentioned that the urobilinogen is formed in the intestine by the bacterial reduction. So when we give the antibiotic will suppress the bacteria in the intestine. That's why there will be a less urobilinogen produced. And the third one is the obstructive liver disease. So that means the bilirubin, the conjugated bilirubin, cannot pass through the bile duct to the intestine, so it cannot convert it to the urobilinogen. And the urobilinogen also we can see increase when there's a hemolytic anemia, when there's a liver dysfunction. So urobilinogen is always associated with the bilirubin. Okay. Okay, blood and myoglobin. So when you see a red color of urine, so the red color, so this may indicate presence of erythrocyte in the urine, hematuria. It could be due to the hemoglobin presence in the urine, hemoglobinuria, or it could be a myoglobin presence in the globin, myoglobinuria. So one thing to take note, students, the blood cell, it cannot cause the glomerular filter. Okay, so hematuria. So the hematuria is a red cloudy of the urine. It's often a combination of intact and also degenerated erythrocyte and also free hemoglobin. So hematuria hematuria is large orange, and there will be the evidence of the lower urinary tract disease. And for the hemoglobinuria, the color of urine, there will be a red to brown in terms of color. But because the RBC is already hemolyzed, so you cannot find the erythrocytes in the sediment, and the plasma, the urine, the plasma color is red, and there will be a anemia. And for the myoglobinuria, there will be a low renal threshold. The myoglobin, it cannot pass easily the kidney. That's why there is a low renal threshold. So this accumulation of the myoglobin in the kidney, it can cause a kidney disease or kidney disorder. And then one more thing to indicate the myoglobinuria is have a clear plasma, and also And one thing to take note and remember, the myoglobinuria, as we know that the myoglobin is related with the muscles, and when there is a muscle degeneration, severe muscle degeneration, and also severe muscle necrosis, so there will be a myoglobinuria. So how we want to differentiate between the hemoglobinuria and also the myoglobinuria. So we can do a special test. We call it as by using of 80% of saturated ammonium sulfate precipitate test. So this one we want to differentiate. So bezakan antara hemoglobin dan myoglobin. So when we add to the ammonium sulfate to the blood and we do a centrifuge, so when the hemoglobin reacts with the ammonium sulfate, so it gives changes the color. So the urine sediment will be yellow in color, whereas if we put if the while for the myoglobin together with the ammonium sulfate, so it not precipitate. That's why it will maintain the red and brown in color. Okay, next one. And for the kidney disease, as we know that kidney disease, the classical laboratory findings related in terms we can monitor, we can observe the blood and also the disease. For the kidney disease, normally we can see the high the term of the urea and creatinine. So there will be a high in terms of the phosphate and potassium to hyperphosphatemia and also hyperkalemia because the body cannot have filtered out this metabolic product. And so there will be a decrease in terms of sodium chloride because the sodium chloride cannot be reabsorbed back, and there will be a albumin and erythrocyte count decrease there. And then we will see a proteinuria and also isotonuria. So this is the classical ataupun kita panggil sebagai normal findings that related. Next. Okay, for the acute kidney disease, we know that for the kidney disease, there are two common diseases, which are the acute and also the chronic. Yeah. For the acute kidney disease, in the blood, we might observe mild to moderate elevation in terms of the urea, phosphate, potassium. But for the sodium and chloride, so there will be a decrease or low normal. So that's why if no dehydration, we might see a decrease ataupun low normal sodium and chloride. So the same goes to the next. Okay, same goes to the albumin and erythrocyte. So we might observe low to moderate low normal. But for the urine, so you will see a proteinuria either 3+ to 4+ by using the urine speed, and there will be also isotonuria in case of the tubular disease. Okay, next one. Next. And next is for the chronic kidney disease. In terms of the urea, the creatinine, the phosphate, and potassium, in case of the chronic disease, it will mark extreme elevation of these parameters. And then for the sodium and chloride, there will be a decrease of the low normal. And then for the albumin and erythrocyte, there will be a moderate to marked decrease. As we know that one of the functions of the kidney is to produce the erythropoietin hormone, and this erythropoietin hormone, so it will act on the bone marrow to stimulate the production of the RBC, the erythropoietin. That's why, in case of the chronic disease, we might observe it will cause a decrease of the moderate to marked decrease of the erythrocyte count, which it gives a non-regenerative anemia. So it's not not non-responsive anemia. But in case of urinalysis, again, we might see a very severe proteinuria for blood by using the urine fit and also the isostonia. Okay, that's one. Okay, next. Okay, now I move to the liver function test. So the liver function test can test for the liver abnormality. And there are numerous tests available, but only a few sensitive and convenient. In terms of the liver function test, we are familiar with the liver enzyme, bilirubin, and also the albumin parameters. So for the liver function test, we have to use the test that you are familiar with here. And then there are a few considerations we should put in order to perform the liver function test. The first one is the parameters are not equally affected by disease. As I mentioned in the early slide, for example, in case of the liver parameters, does not indicate a specific liver disease, but it only tells us the liver system is affected. And then, in case of the serum abnormalities, we can see changes in terms of the serum after extensive damage to the liver. And then, one more thing is the functional impairment may occur before lesion or vice versa. For the liver function test, actually there are many tests also available. But we are not usually rely on it. Like for example, tests of the peripheral blood uptake, conjugation, secretion, and serum secretion like serum bilirubin, and test of the blood clearance, ammonia tolerance, and bile acid. And the third test is test for the hepatic synthesis. This we can monitor glucose, albumin, urea, and also the clotting factors. Okay, next. Okay, so the liver function test. There are two basic groups of tests for assessing the liver function. The first one is screening test, and number two is specific purpose test. And for the specific purpose test, it's a test done after screening tests are positive. And we use it to identify abnormalities which may be due to the leakage of enzyme from the liver parenchyma. When there's a liver injury, liver degeneration, and also liver necrosis, so the enzyme will be released from the cytoplasm of hepatocytes into the blood circulation. So in case of the cholestasis, the bile duct obstructions, they are enzyme related like alkaline phosphatase and also the gamma glutamate transferase, the GGT, and also in case of the reduction of the functional mass like hepatic cirrhosis, which is observed in case of the chronic liver disease. Okay, these are the list of the liver enzymes. I believe that you are familiar, have been taught in your class by your respected lecturer and docent. And then in case of the alanine aminotransferase, which is also known as ALT, is very high, especially in dogs and cats, and this is the liver specific. So every time we want to check for the specific liver disease, we want to check the true liver disease, we have to look on the alanine aminotransferase ALT in case of dog and cat. And then for the AST, we can observe that it's very high in equine, in horses, but it's not liver specific. Why? It's also present in muscle, kidney, pancreas, and erythrocytes. That's why we see that horse is a very big and large animal. It may have a high AST enzyme because this enzyme may present in the muscle. And then the alkaline phosphatase enzyme, again, this is not liver specific, but alkaline phosphatase is one of the cholestatic enzymes. So it's moderately in dog, but low in cat, but it's also moderate in the ruminant and high in equine animal. And gamma glutamate transferase, so this is the preferred enzyme in case of the ruminant animal, but again, it's not liver specific. It's also associated with the cholestasis, and then it present in the kidney, pancreas, and also intestine. So other liver enzyme is the lactate dehydrogenase. So lactate dehydrogenase, it has 5 isoenzymes. So what is isoenzyme? Isoenzyme is a similar function, but it's a variable in the molecular structure. So ruminant animal like bovine, like cattle, so it contains high LDH, but again LDH is not organ specific because it also present in other organs like muscle, lung, kidney, placenta, pancreas, and others. And the last one is a sorbitol dehydrogenase. It's a moderately available in the ruminant. The special thing about the SD is a liver specific, but for most species, but it's low in the serum activity. And the SD, the sorbitol dehydrogenase, it can be used to detect hepatic disease in cattle and also in horses. Okay, next. So one more thing about the liver enzyme. So we have to know the concept of the half life. The knowledge of the plasma enzyme half life is most important in the assessment of a disease process, and it helps us to determine the policy. Let me give you an example. So if high plasma enzyme drops by 50% every 2 to 4 days, for the enzyme to be half-life 2 4 days, so the prognosis is good. But if the high enzyme concentration persists in plasma or the concentration diminish less than 50%, we can say that the animal has been suffering the persistent disease or minimal improvement. And the last one, if the enzyme concentration continues to increase, so it indicates the disease is rampant, the disease is uncontrollable. This is uncontrollable. So it's very important for us veterinarians and the veterinary students to understand the concept of the half-life of the enzyme. So next. So this is the half-life. Like for example, alanine transaminase, there are many differences. They put 4 hours to 7 days of the half-life, but in average, the half-life for ALP together with ASP is about 3.5 days, 3 days and a half for their half-life. And for the GGT, the half-life is 4 days. And for the alkaline phosphatase, we can look here, the half-life is about the 6 hours, maybe equal up to 3 days. So, but for the liver, but then ALP produced by the placenta, the kidney, and the intestine, the half-life is less than 10 minutes. So that means most of the time if we see high alkaline phosphatase, it's due to the liver. And then for the bilirubin and the albumin, so it persists longer in the blood circulation up to 2 to 3 weeks. Next. Okay, bilirubin. So bilirubin is always associated with the liver, with the metabolic product of the hemoglobin, and from the hemoglobin it's converted into a bilirubin, and then again it will converted to become the unconjugated bilirubin, And the conjugated urine will pass down to the bile duct, and it will enter the intestine, and it becomes the urobilinogen. So the urobilinogen, so it takes the intestinal enzyme reaction, intestinal bacteria reaction, and generally bilirubin can be classified into two types: the unconjugated urine and also conjugated urine. So unconjugated urine, also known as a free urine, is bound to albumin. It will go to the liver, and it has a high renal threshold. That means it can pass the glomerulus easily compared to conjugated urine. While conjugated urine is a water-soluble bilirubin, and it has a low in terms of the renal threshold. Okay, next. And then we are interested in the hyperbilirubinemia. So hyperbilirubinemia as a result of increase in the plasma concentration of conjugated bilirubin, the unconjugated bilirubin, or both types of the bilirubin. So when we can observe or we can see the unconjugated bilirubin, like the first one due to the increase of the hemolysis. The hemolysis could be due to the parasitic infestation like Babesia species, the Trypanosoma species, or due to the isoimmune hemolytic, and also hemolytic anemia. So the unconjugated bilirubin concentration in blood, when there is a hemolysis, there will be a lot of the unconjugated bilirubin, so it will exceed the capacity of liver to go the conjugation process. So in case of unconjugated bilirubin, we can see also in case of the neonatal defect in the hepatic intracellular binding and conjugation, in defective erythropoiesis, so there are defects in the red blood cell, the morphology of the red blood cell due to the folic acid and vitamin D deficiency. As we know that the folic acid and vitamin D are very, very important for the production of the red blood cells in the bone marrow. And in case of the antibiotics and tranquilizer, so it will compete with a bilirubin for the glucuronidation process in the liver. And next one, increase of the conjugated bilirubin, and this increase of conjugated bilirubin associated with the obstruction in the biliary flow. When the bile duct is obstructed, so there will be a conjugated bilirubin. When there is a hepatocellular damage and then cholestasis, again it will lead to the conjugated. It will lead to the hyperbilirubinemia. Okay, next one. Okay, the slide just to show you the changes in the plasma bilirubin concentration different between the pre-hepatic, hepatic, and also the post-hepatic. So in case of pre-hepatic, we can observe more bilirubin, high bilirubinemia, especially due to the unconjugated bilirubin. And for the hepatic type, due to the conjugated bilirubin. Meanwhile, for the post-hepatic jaundice, is always associated with the high conjugated bilirubin compared to unconjugated. But this one is just information for us. So in real case, there will be a slightly changes, so it not follow the typical one as we discussed. Okay, next please. And the next one is about a plasma protein. So plasma protein or protein is very important in clinical chemistry. And one thing to remember, the major site for the production of the protein is the liver. And other than that, the lymphoid system, the plasma cells, the lymphocytes also deals in the liver. And then we have learned in our study that the protein is very important in terms of the structure of the cell, tissue, and organs. It maintains the colloid osmotic pressure. Protein is very important for the biochemical reaction. cell regulation, the blood coagulation, the coagulation factors are made up of a protein, the immune system, the transport and carrier protein like albumin, and also a protein important function as a nutrition to the animal. So, okay, that's fine. For the serum protein fraction, so actually it can be divided into three types: the albumin, and also globulin. And then based on the literature, the free albumin may not exist in domestic animals, but it exists in some of birds. And then the major types of the albumin is a major type of the protein is the albumin. So the albumin is up to 35 to 50% of the total serum protein. And then for the globulin, there are three major fractions. So in order for us to differentiate type of the globulin, we have to do the electrophoresis. And basically, there are two types, which are the alpha globulin, the beta globulin, and also the delta globulin. Okay, next one, please. Okay, acute phase protein. And nowadays, people talk about the acute phase protein. So what is acute phase protein? This is a group of blood protein which concentration changes in animal subjected to changes. So when there's an infection, inflammation, physical trauma, and such, there will be changes in the acute phase protein. So nowadays, people use the APP as a diagnostic biomarker of the various diseases, and not only medical but also in the veterinary world. So APP, we have two types, negative APP and also positive APP. So negative APP usually it will decrease in response to challenge. There are two examples of negative APP, which are the albumin and also transferrin. And then positive APP usually it will increase in concentration in response to challenge. This is the interesting part. The positive APP like haptoglobin, CD protein, fibrinogen, the serum amyloid A, the ceruloplasmin, and alpha-1 glycoprotein. So people now interested with the positive APP to indicate as the early disease marker. Okay, that's one. So people use acute phase protein to monitor the inflammatory process, but not but also it also used to monitor the non-inflammatory process. So pregnancy, population, any metabolic diseases and such. So we should rely in the future the use of the. So next one is. And these are the example of the acute phase protein in response to the stimuli. Like for example, in dogs, the dogs have a high concentration of the CRP, C-reactive protein, and there's a product in the market to detect CRP level in dogs, the specificities, and then for the ruminants have a high concentration of the haptoglobin and also for the horse, serum amyloid A is the most type of the APP which is produced in case of the infection, inflammation, and others. So we can use this information for us to help us in order to diagnose the progression of the disease, the prognosis of the disease based on the APP. Next one is. So that's why this proteinemia. So this proteinemia is the presence of the normal plasma protein in the blood, but it's abnormal concentration. So protein is made up, the total protein is made up of the albumin and also the globulin. So from here we can make a ratio. Yeah? We call it as the A to G ratio. Okay, there will be a normal A to G ratio decrease of the A2G ratio and also high A2G ratio. So when we talk about low A2G ratio or decreased A2G ratio, it always related with low albumin and high globin. So low albumin in the blood circulation, how it occurs? The first one because of the loss of the protein or loss of the albumin due to the rare disease. So this one we call it as the loss of the kidney and also so protein loss deformity and then some of the protein it can be lost through the small intestine due to the gastrointestinal disease. So we call it as the protein losing enteroprotein. So protein losing enteroprotein. And then low albumin also due to the decrease in terms of the synthesis. So as we know that, as we understand that the liver is responsible to reduce the protein. So when the liver is affected due to the infection or due to the cancer, so there will be a chronic liver disease, so it will less numbers of the protein will be produced. Same goes with the malnutrition. When the animal when the animal having a long starvation, the animal not having enough food, not enough protein, so that's why there will be less protein. So same goes with the chronic inflammatory. So hyperglobulinemia means high globin concentration in the blood. It could be due to increased alpha globulin, increased beta globulin, beta, so gamma, BG, polyclonal gammopathies, and also monocytic gammopathies. So the next one. Okay, next one is the increased A2G ratio. As I mentioned, increase of the A2G is due to the high albumin and low globin. So high albumin is occurs only with a dehydration. Yeah? So dehydrated animals they will be high in terms of the in the albumin and the low globulin. So what cause of the low globulin? It could be due to the fetal serum, the free cholesterol unit, and also combined immunodeficiency, where we can observe in the Arabian code. Okay, next one. So next one is a muscle detection, muscle functional test. So this muscle functional test is a laboratory detection of the muscle disease. This can be done for the estimation of the muscle leakage enzyme either in the serum or myoglobin. Yeah. So there are four common types of the muscle leakage enzyme: the creatine kinase, the aspartate transaminase, the AST, lactic dehydrogenase, and also aldolase. And between these four enzymes, the most common one is the creatine kinase. As we know that the creatine kinase, it has the creatine kinase is present in the cytoplasm of the myocyte. So when there is a muscle degeneration or muscle necrosis, so this enzyme will be released out, so it will enter the circulation. And the creatine kinase or CT is a very sensitive muscle enzyme, so it can be used as the detection of the muscle disease. It has a short half-life, only 6 hours, and then it has a three isoenzyme MM, which is in the skeletal and cardiac muscle, MB, skeletal and cardiac muscle, but very small quantities, and the BB, brain tissue. But high isoenzyme is located in the skeletal and also the cardiac muscle. Okay, next. So increase in CK serum concentration, it may indicate reversible injury and necrosis of the muscle. So it reach maximum value by 12 hours. and that it can return so normal 20 to 48 hours after the injury cease. And then it can be used together with the AST in determining the prognosis. And then the CK, AST, the lactate dehydrogenase increase mildly in exercise and also regular training. So even in the exercise animal, like in the horse, there will be after the training, exercise and regular training, we might see a slight or mild or moderate increase of the creatine kinase. As I said in the beginning, the creatine kinase is a very sensitive muscle enzyme compared to the others. And then for the central nervous system also, the CK, the creatinine will increase in the cerebrospinal fluid in case of the encephalomalacia. So what is encephalomalacia? Encephalomalacia is a softening of the fluid. Okay, next please. And other liver enzyme, other muscle enzyme is the aspartate transaminase, AST. This one have a short half-life also. So it have a longer half-life compared to the peptide kinase, which is 2 to 4 hours. And then one more thing to take note, students, the AST also produced by the liver. So when the animal having a problem, having a disease, and the other liver parameters are normal, so you can suspect the increase of the AST is due to muscle injury. And one more thing we should take note, the AST it have a slower, it increases slower, but it persists longer compared to the compared to the peptide kinase. And then for the lactate dehydrogenase, it's not a specific enzyme because it's also present in other organs. And then it also have many enzymes, and any hemolysis it can increase the serum lactate dehydrogenase. And then the enzyme number 1, the LD1, it will increase some of the cardiac disease of hemolysis. While the LD5 it increase in case of the skeletal muscle and also liver disease. Okay, next please. And other enzyme but less common is the aldolase. This one is the increase also the serum activity in case of the muscle disease, but compared to CK, AST, aldolase is less capable, and at the same time also is a less specific muscle for the muscle disease, muscle degeneration, and of course is compared to the creatine kinase. So another parameter that we can check in case of the muscle disease, we can rely on the myoglobin. This is type of the protein which is present in the muscle. And then in case of a severe muscle injury, muscle necrosis, we might observe the presence of the myoglobin in the urine. So we call it as a myoglobin. Okay, that's right. And now I move to the digestive system. There are many organs associated with the digestive system. So I would like to start first with the pancreas. So pancreas, they have two main functions in terms of endocrine and also exocrine function. So endocrine function, so it consists of the islets of the glands, which secrete 4 hormones: the insulin hormone, the glucagon, the gastrin, and also the somatostatin hormone. And also, the pancreas, it also has the exocrine property. So it will secrete up to 2 liters of fluid rich in digestive enzyme from the acidic side. So the enzyme like lipase, the amylase, the trypsinogen, the protease enzyme. So this enzyme will help for the digestion and absorption of the nutrients in the intestine. Okay, next one please. Okay, diseases of the pancreas. I would like to focus on the diseases. It's easier for us to understand. So pancreatitis, inflammation of the pancreas, it could be acute or it could be the chronic pancreatitis. So what causes of this pancreatitis is due to the infection, systemic infection. It could be a duct obstruction, any vascular disease, toxin, trauma and also metabolic disorder. And then there's a pancreatic insufficiency. So lack of the pancreatic enzyme produced, it can be caused by the repeated attacks of the acute pancreatitis, or it could be due to the chronic pancreatitis. So another one, the diabetes. As we know that diabetes is related with the glucose metabolism. There will be a hyperglycemia. There will be high in terms of the glucose in the blood circulation. And most of these disease, it can result in a severely diminished pancreatic endocrine function. It will compromise the digestion and also the absorption of the ingested nutrients. So, in order for us to test the capacity, the normal functional capacity of the pancreas, we can do a secretin test. So, secretin is a type of hormone. It's a hormone produced by the small intestine. So, from here, we can determine the exocrine secretin capacity of the pancreas. Either the pancreas is able to produce and also to release the enzyme, such as the lipase, the protease, the amylase, etc. How are we going to do that? We can administer secretin intravenously after 6 hours or overnight fasting. So the interpretation is, when there's a low fluid volume, it characteristic of the pancreatic duct obstruction. But when there's a low bicarbonate concentration, it will suggest the chronic pancreatitis. And when there's a decreased flow, it may be due to the tumor of the pancreas. Okay, next one. And then we can look on this on the enzyme. We can measure the enzyme amylase and also the enzyme protease. So this common enzyme associated with the pancreatic diseases. So it will be increased when there's an acute pancreatitis, and there will be an increase in lipase more persistent than amylase. And typical response is the increase of this enzyme, the amylase and lipase, within a few hours after the onset of the disease. So it will peak after 1 day, and then after 2, 3, 5 days, it will return to the normal. And this enzyme, how it have a high concentration in the blood? Because the enzyme leaks from the pancreatic cells. When the cells undergo necrosis, there will be leakage of this enzyme, so it will enter to the blood circulation. So another point is this enzyme also excreted by the kidney. So when the animal having the kidney disease, you can observe, you can see hyperamylasemia and also hyperlipasemia. But the one limitation related with the amylase and lipase enzyme is not specific. It can be a non-specific, especially in terms of the prostate gland, yeah. Because the prostate gland, it can also produce the lipase and amylase enzyme and also the salivary gland. Okay, next. And next one is the TSI, the trypsin-like immunoreactivity TLI test. This one, the TSI, also leaks from the pancreas into the blood circulations. And then how we can do this test? We can fasting the animal for overnight, and then later we should collect the blood and monitor for the TLI test. And the normal dog should have 5.7 to 45.2 microgram per liter of the TLI time. So when the result less than 2.5, so it's a diagnostic for the exocrine pancreatic insufficiency, EPI. But if the result 3.5 to 5.0, so this reflects a subclinical type, and then it's above 50 microgram per liter of the TLI enzyme, so it's consistent either with acute ataupun chronic pancreatitis. Okay, next one. And then for cats, similar to the cat, less than 8.0 is diagnostic for the exocrine pancreatic exocrine pancreatic insufficiency, but if more than 100 microgram per liter, it is consistent with the acute or chronic pancreatitis. Okay, next. Next, please. Next one is a pancreatic lipase immunoreactivity. Then again, we have to fasting the animal for overnight before we collect the serum samples. So the normal reading is 0 to 3.5 microgram per liter in case of cat, and then for canine 0 to 200 microgram per liter. So when there's a high concentration of the PLI, so it will indicate of pancreatitis. Okay, that one is. Okay, another one, serum protease that we can check is the alpha-1 protease inhibitor. So this one, alpha-1 protease inhibitor, usually it helps us to diagnose of the protein closing and properties. So what are they? They are IBD, infectious bowel disease, intestinal lymphoma, a malignant type of a tumor in the intestine, the elephantiasis, and also the histoplasmosis. So why we can rely on the alpha-1 protease inhibitor, because this type of protein is resistant to the intestinal bacterial degradation. As we know that in the intestines there are protease, yeah, and enzyme breakdown protease, but this enzyme it resists towards the bacterial degradation. That's why in case of the protein lesion enteropathies like IBD and etc., we might observe increase in the serum protein concentration of the alpha-1 protease inhibitor. Okay, next. So the slide show you the A and also B. If you look the A1, after being lost into the ancestral lumen, albumin and other plasma protein are degraded by the digestive and also the bacterial proteinase. That's why the degradation product are not immunoreactive and they cannot be measured by the immunoassay. In comparison to the alpha P1, it cannot be degraded by the proteinase. So it will be made in the intestinal lumen. That's why it can be detected by the immunoassay. Okay. And other for the gastrointestinal tract diseases, we might see a chronic, we might see anemia due to the chronic malabsorption. This is the characteristic of the chronic type of anemia, chronic diseases. When there is an infection also, we might see an inflammatory leukogram, characteristic of the leukocytosis. And when the protein loss through the GI tract, it will be hypoalbuminemia, but it can be masked by digestion. And then, in case of the infection, we might see also hyperglobulinemia, and there will be albuminemia, which is the GI tract disease. When there's a bleeding, it will be hemorrhage. And below that, the blood also contains a high rich protein. That's why it is the of the blood media nitrogen. So you receive albuminemia. So, in case of the malabsorption of the nutrients, that's why you might see presence of the fecal fat, carbohydrate, and also protein in the feces. And then it also related with the hyponatremia, sodium loss, in case of the dehydration, hyperkalemia, in case of dehydration, hypokalemia associated with diarrhea, hypochloremia associated with diarrhea, and in case of diarrhea also we might see acidosis, hyperkalemia, whereas for the vomiting, the animal having a vomiting, there will be alkalosis and hypokalemia. And the same goes with the pancreatitis. The common parameters, serum biochemical parameters associated with pancreatitis, there will be hyperproteinemia due to the hyperglobulinemia. There will be a globulin produced by the body. There will be also azotemia. And then due to the pancreatitis, it can cause ascending infection from the pancreas to the liver. So they will cause a liver problem, liver disorder. That's why we might see a case of the ALT, case of the alkaline phosphatase. There will be hyperbilirubinemia, which can lead to jaundice later on. And then at the same time, you might observe the hypercholesterolemia, hyperglycemia, hyperamidemia, and also the hyperlipidemia. Okay, next one is, and then we come almost to the end of the session today. The last one, we can do the fecal elimination in case of the eye tract, so with fecal fat. So the idea is when the animal fecal fat is usually the sources is due to the unabsorbed ingested lipid and lipid excreted intestine and cell shed intestine metabolism of the bacteria. So the fecal fat, so we should take the fecal and then as a mean, then we need a kind of special stand, like for example the Sudan 3 and Sudan 4, and this one we might see a presence of the fat that present the fat that presents the feces. So when we put the Sudan 3 and Sudan 4 stain, that's why the fat also can appear large or red and full white of them. So this one we call it astoria, presence of the fat in the feces. They can do also you can use a Lugo stain, this stain for the starch. Because of the animal having a mild absorption, mild digestion, the starch it cannot not probably break down, not probably digested, so it cannot absorb the small intestine and circulation. That's why it will end up to be out together. Why is this Lugo stain? So this tends to be the starch donor blackish purple color. And same goes with the gelatin digestion fat stain. So this one, in order for us to detect a trypsin and chemolysis in the feces. And I think the next slide, please. And next one is a fat absorption test. So this one is absence of the plasma turbidity indicate lack of the fat absorption. And then we might also find the undigested muscle fiber. This is a presence in feces of meat eating animals. So indicate that deficiency in protein digestion. As I mentioned just now, because of the improper protein digestion, so the muscle fiber cannot be digested and cannot be absorbed by the intestine. And we can do other fecal elimination because the GI tract disease is not limited on limited to the enzyme and also enzyme, but also associated with the infectious agent could be presence of the parasite, the helminth, the virus and the bacteria. That's why we have to do a vector culture. We can also stain the disease right stain so that we can look for the presence of the inflammatory cells like neutrophils, so that we can suggest inflammation of the colon, inflammation of the intestine, arthritis, and so on. And then we should evaluate again, as I mentioned, presence of the fat, starch, muscle fibers, and also further the enzyme. And the last one is we should do the OCAP blood. OCAP blood does because we want to detect any presence of the blood loss, the minute amount in the intestine. So I think next slide, please. Okay, I think that's all for the sharing today. I cannot make it. I cannot discuss a few systems more because of the due of the limitation of time, and I deeply appreciate the opportunity given by the Urine to share these things there. I hope that you can grab some important points that have been highlighted. And again, I believe that the subject also already covered by your respected lecturers in your company. And that's all from me. Thank you. Thank you to MK for giving me the opportunity.
Dr. Kandel.
Halo, Dokter Ganda.
Dr. Kandel, selanjutnya.
Ini Dokter Farhan juga keluar. Maksudnya kehilangan sinyalnya.
Selanjutnya apa?
Selanjutnya diskusi dok, tapi Dokter Farhan belum bergabung kembali.
Dokter Ati suaranya tidak muncul itu.
Mohon maaf, sepertinya Dokter Gandul ada gangguan, suaranya tidak bisa masuk. Mohon maaf, sementara akan saya bantu untuk selanjutnya. Sesi selanjutnya yaitu adalah sesi tanya-jawab dan diskusi. Maksud saya sesi diskusi, silahkan bagi Bapak Ibu atau rekan mahasiswa yang ingin bertanya kepada Dr. Farhan terkait apa yang telah disampaikan, bisa menyampaikan melalui chat ataupun melalui secara langsung, bisa raise hand terlebih dahulu untuk bisa mendapatkan kesempatan bertanya kepada beliau. Silahkan yang ingin bertanya. Ya, ada yang ingin ditanyakan? Sebentar. Apakah ada kesulitan untuk bisa berbicara langsung? Ada yang bisa raise hand?
Atau mungkin bisa just di chat.
Langsung menyampaikan namanya jika kesulitan untuk melakukan raise hand. Terima kasih Dokter Farhan. Sepertinya penjelasan Dokter Farhan sangat-sangat jelas dan bisa dipahami oleh seluruh mahasiswa. Terima kasih banyak atas penyampaian dokter yang sangat menarik dan sangat memberikan informasi baru bagi kami. Tentunya beberapa hal yang tentunya juga memberikan pandangan lebih bagi kami di sini, di mana seperti pemeriksaan yang sebelumnya belum kami sampaikan, yaitu pemeriksaan dalam bentuk otot, kemudian muscle disease dan lain sebagainya. Itu merupakan tambahan yang sangat baik bagi kami. Terima kasih banyak atas waktu yang Dokter Farhan berikan di sini. Thank you very much for your time, for your we are very ini benar-benar merupakan kesempatan terbaik kami bisa memiliki Dokter Farhan dalam kesempatan ini. Terima kasih banyak. Untuk selanjutnya saya sampaikan kepada MC untuk melanjutkan acara.
Baik, terima kasih kepada Dr. Gandul Ati selaku moderator, dan terima kasih kepada Dr. Muhfarhan Hanif bin Redwan DVM selaku pembicara kita pada pagi hari ini. Kami harapkan kepada seluruh peserta untuk tidak meninggalkan room terlebih dahulu karena akan ada sesi foto bersama pada akhir acara. Baik, acara selanjutnya adalah penyerahan sertifikat secara simbolis kepada pembicara dan moderator, yang dalam hal ini akan disampaikan oleh Dr. Rohmah Kurniasanti selaku Ketua Divisi Kedokteran Dasar Veteriner. Maksud saya selaku Ketua Divisi Kedokteran Dasar Veteriner, Fakultas Kedokteran Hewan Universitas Airlangga. Kepada Dr. Rohmah Kurniasanti kami persilahkan. Atau mungkin kepada Dr. Nova?
Ya. Ya.
Kami persilakan, Dokter.
Terima kasih. Dr. Farhan, on behalf of Faculty of Veterinary Medicine Erlangga University, let me say thank to you for your very useful lecture to our student today. I hope after this occasion there will another collaboration again. Dr. Farhan, on behalf of Faculty of Veterinary Medicine, Erlangga University, let me give you a certificate. Thank you for your kindness. Harapan saya nanti ada kolaborasi lagi di kemudian hari dengan Dr. Farhan lagi nanti. Ya. Terima kasih Dr. Farhan atas kesediaannya untuk hadir memberikan kuliah tamu.
Pada bagi ruang dan I hope that berharap tentu saya bisa kemudian ke Airlangga untuk bertemu dengan dosen dan semua lecturer dan semua mahasiswa. InsyaAllah semoga COVID-19 akan berakhir dan saya bisa Malaysia. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Dr. Farhan, thank you.
Terima kasih Nitya. Terima kasih Bu Nova.
Mbak MC, selanjutnya.
Baik, selanjutnya penyerahan sertifikat kepada moderator yang akan diserahkan oleh Dr. Nova kepada Dr. Gandul Ati. Kami persilakan.
Ya, terima kasih Dr. Gandul yang juga telah menjadi moderator hari ini untuk guest lecture hari ini. Nanti semuanya hari berlanjut kegiatan seperti ini. Terima kasih sudah menjadi moderator. Kembalikan kepada
Baik, terima kasih Dr. Nova. Kami ingatkan kepada peserta webinar untuk melakukan absensi dan menggunakan link yang telah dikirimkan pada kolom chat. Baik, sebelum kita mengakhiri acara webinar pada hari ini, terlebih dahulu kita akan melakukan sesi foto bersama. Baik, kepada yang bertugas, langsung saja kami persilakan.
Baik, sesi foto ini akan dilanjutkan. Untuk sekarang slide yang pertama, silakan berikan videonya dan berikan play. Terima kasih. Kemudian slide yang kedua. Tiga. 4, 5, 6, 7. Dan sudah selesai. Terima kasih.
Baik, terima kasih Dr. Nani. Alhamdulillah dengan berakhirnya acara ini, kami ucapkan terima kasih sebanyak-banyaknya kepada pemateri, kepada panitia penyelenggara, beserta seluruh peserta yang telah antusias mengikuti webinar pada hari ini. Saya selaku MC, mohon undur diri. Mohon maaf apabila ada tutur kata yang kurang berkenan. Semoga kita bisa mendapat ilmu baru pada hari ini dan siap untuk diaplikasikan di kemudian hari. Akhir kata, saya mengucapkan wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Selamat siang, salam sehat.
Terima kasih Bu Farhan.
Terima kasih.
Farhan.
Terima kasih Dokter Farhan. Sehat dok?
Ya.
Reuni ya.
Sebenarnya tak dengar.
Tak dengar.
Sorry dokter, tak dengar dokter suaranya dekat sini.
Kurang
tak dengar kan?
keras.
Tak dengar.
Okey. Tadi masa saya lecture tadi, suara clear ke atau tak clear ya?
Clear. Masa presentation suaranya clear.
Kak awak sihat ke? Mbak An sihat?
Sehat, alhamdulillah. Rindu ya, lama tak jumpa ya.
Wah, gitu dah.
Ditunggu ya nanti insya Allah kalau COVID dah reda, Dr. Farhan datang ke fakultas.
Iya.
Sama saya ingat juga Kak, Dokter Farhan.
Iya.
Ya lupa.
Pasti ingat lah.
Buat
So, Dr. Farhan dekat Kelantan?
dekat Kelantan. Sekarang musim hujan, hari-hari hujan.
Hari-hari hujan.
Wow.
So, macam mana situation COVID dekat sana?
COVID sekarang ni Malaysia dah kes dah naik dah dekat dalam 1,500, 2,000 lah setiap hari. Tapi kerajaan tak buat dah. Macam lockdown ke apa tak buat dah. Macam kita kena COVID lah.
So, campus activity sekarang semua buka online ya?
Kalau campus activity online, mahasiswa semua di rumah. Tapi ada mahasiswa tahun akhir, student study ya, dia untuk buat projek.
Semoga sehat selalu, dokter. Dan
Nanti kirim salam kepada semua ya.
Insya Allah disalamkan.
Dapat salam dari Prof. Anwar tadi, Dr. Farhan.
Kirim salam pada Prof. Anwar. Prof. Anwar sudah jadi dekan ya?
Iya. Alhamdulillah sehat-sehat. Alhamdulillah.
Okey, Ibu semua terima kasih ya. Assalamualaikum.
Salam. Terima kasih Dr. Farhan.
Terima kasih Bu Ani, Bu Aan, Bu Nova.
Sami-sami.
Sama. Sukses ya.
Sukses. Alhamdulillah caranya.
Halo.
Oke,
Nah itu
semuanya ya.
Gandul kelihatan dengaran.
Kok baru jelas. Tadi nggak nyuara. Sekarang baru jelas.
Sudah selesai. Suaranya.
Nah, tapi sepertinya memang beberapa kali departemen kemarin juga mikrobiologi seperti ini Bu. Jadi suaranya putus-putus kayak robot gitu. Nggak lancar. Nggak tahu kenapa, masalahnya dari mana.
Cuacanya.
Mungkin karena cuaca juga, betul.
Untung Bu Nova tanggap ya. Langsung di handle.
Gerak cepat, gercep ya. Alhamdulillah.
Semuanya siap tadi.
Alhamdulillah.
Iya.
Bu Miayu, ada Bu Kade, tadi Bu Ira, terima kasih Bu dosen yang hadir. Kan lengkap sekali ya materinya dokter, complete.
Iya, betul.
It's enough.
Dr. Farhan ini terkenal orangnya low profile.
Oh iya.
Kita bantu ya.
Dokter, ditunggu jemputan kawinnya loh. Saya boleh ya announce dekat sini ya? Saya announce dekat sini ya.
Barokah ilmunya, dokter.
Sama-sama. Saya pun mahu belajar dari semua dosen-dosen.
Tadi sempat Bu Dekan ya, sudah bertemu Bu Dekan tadi ya. Sudah ya.
Bu Dekan yang membuka tadi.
Ya.
Udah kenal kan dulu ke perikanan juga kan ya?
Dokter Farhan sudah pernah jumpa dengan
ya,
Urinalysis sebelumnya? Sudah pernah berjumpa?
Fisheries.
Belum
Faculty of Fisheries.
Ini
belum pernah
kalau waktu kesini Dokter Farhan
ya?
mungkin nggak sempat ketemu.
Oh, ke pasca ya waktu itu.
Surabaya.
Pasca.
Ya. Alhamdulillah sehat semua ya. Ya.
Katanya metu sungkan kira.
ini.
Menunggu makan siangnya ya, nasi lemak ya. Apa deh?
Nasi lemak.
Kalau di
nasi lemak biasanya untuk makan pagi.
Dokter biochemistry siapa Dokter Farhan di Kelantan? Biochemistry siapa? Biochemistry yang ngajar biochemistry. Veteriner biochemistry. Ada dosennya siapa?
Oh, di fakultas saya Dr. Madinah itu yang ada biochemistry.
Oh, iya. Depan nanti kolaborasi lagi untuk kuliah dengan Kelantan nanti untuk juga nanti. Ya.
Nanti Ibu bisa dapatkan saya nomor HP nanti saya juga membagikan kontak-kontak. Bisa dihubungi lah untuk kolaborasi kuliah, research dan lain-lain.
Ya. Ya, terima kasih. Ya. Salam dari teman-teman semuanya. Belum bisa bergabung hari ini.
Udah live ya?
Ada biasanya belum ada kabar nanti kabar dulu. Kalian
Mbak
ya?
Kegiatan ini juga.
Kemarin yang mikrobiologi juga gini.
Sama Dokter Gandul. Iya, jadi awal-awal itu masih lancar. Terus pertengahan pas presentasi itu suaranya kayak menggema gitu. Jadi ya sama koneksinya enggak bagus. Ya,
awal sama akhir.
Pas presentasi masih nggak ada masalah, tapi setelah itu kayak suaranya tuh kayak menggema gitu, kayak robot gitu. Jadi sampai
bukan belas nggak keluar tadi ya suaranya.
Berebet, sing berebet suaranya. Aku
bukan dulu nggak belas.
Aku deg-degan emang.
Kalau tadi Bu Endang berebet kayak robot. Parasit tadi.
Sama enggak keluar juga suaranya awalnya.
Ini Bu Ani ya.
Kenapa?
Parasit kesini ke PK gitu.
Apa buka dua-duanya?
Buka dua-duanya, dua device.
Nginceng kono, nginceng gini.
Anak-anak pokoknya nggak buka video yo.
Iya. Tadi
Parasit video tadi.
Pagi itu sudah backup ini PPT-nya ke saya. Makanya beliaunya tutup kamera, saya tutup kamera, saya share screen bisa. Jadi yang share screen tadi kan saya.
Oh, gitu.
Untungnya pagi sudah kirim PPT sudah. Ini buat backup.
Antisipasi.
Iya, antisipasi.
Ini buat backup saya kirim untuk backup dokter gitu. Nah ya untung. Jadi begitu beliau enggak mungkin kan terus minta saya yang buka, saya sudah siap juga. Alhamdulillah nanti bisa dievaluasi untuk pelaksanaan guest lecture mendatang. Ini bentar lagi biokimia.
Iya, belum memberi jawaban. Siapa Pak Dokter Helmi, istrinya kan habis melahirkan gede kemarin. Saya Japri kok belum membalas. Aku sungkan pas engko ono apa-apa bojone. Habis
Ini sebetulnya kan hari Selasa, terus beliaunya ada tugas, terus minta ditunda. Saya minta hari Sabtu aja karena nanti Selasa depan itu sudah ujian praktikum.
Iya.
Mahasiswa sudah ujian praktikum, nggak bisa pakai Zoom.
Kalau lebih dari tanggal 22 nggak bisa ya, diklaim ya. Misalnya mau anggaran 24 gitu nggak bisa lagi ya.
Oh, udah tutup ya anggarannya.
Misalnya gitu. Nek oleh ya pas liburan nih mau jadi ya santai hari libur itu. Iya. Mungkin nanti kalau guest lecture itu kan satu orang ya. Kalau webinar itu bisa seminar tuh 2 atau 3 ya. Kalau ini kan 1 ya kalau guest lecture itu ya.
Kemarin mikrobiologi 2 orang, Bu Nova.
Oh, 2 orang.
Lecture, iya.
Oh, gitu. Oh, lain
Iya.
kali saya buat 2 ya. Nanti kalau satunya berhalangan enggak satu-satunya begini ya. Pengalaman buat kita nanti kalau ada halangan jadi bisa pakai satunya gitu. Ya, pengalaman buat kita. Mungkin lecture tuh 2 atau 3 enggak apa-apa mungkin ya. Satu dikasih topik sendiri-sendiri nanti.
Iya, topiknya berbeda.
Nah, itu pengalaman buat kita. Kalau tiba-tiba ada halangan jadi tetap terlaksana.
First time.
Iya, bagus kok ada ini, ada guest lecture tuh bagus. Terus mungkin juga perlu juga yang seperti dilakukan PK. PK ini memanggil praktisi untuk kuliah juga. PK. Kita mungkin masing-masing, aku kok usul ya, kok lancang ya.
PK itu ini kan?
Kan Merdeka Belajar gitu, Bu. Jadi kita
lancang.
Di luar, tapi praktisi diminta ngajar di dalam.
Iya saja nih.
Prinsipnya Merdeka Belajar gitu.
Ya. Jadi tidak hanya teoritis ya, praktisnya ya. Tapi juga harus hadir di situ untuk praktekkan karena sekarang pandemi, jadi semua serba online. Jadi itu termasuk Merdeka Belajar sebetulnya. Tapi kok lancang ya ngomong sih ya. Iya wacana. Ya. PK ini inovatif ya, manggil praktisi, juga manggil guest lecture. Jadi apa yang diberikan mahasiswa itu bisa bukan sebuah teori, jadi bukan awang-awang, jadi kenyataan yang ada di lapangan. Jadi kalau teori kita berikan, nanti apa yang ada di masyarakat itu mahasiswa bisa mengaplikasikan teori dasar itu. Kita kan berikan yang dasar biasanya lah. Itu anak-anak itu biasanya kan nggak tahu bagaimana yang ada di lapangan. Jadi yang biasa di lapangan itu ikut memberikan itu. Jadi bukan awang-awang.
Untuk menambah wawasan mahasiswa.
Ya, kasus-kasus yang banyak di lapangan itu.
Banyak yang belum kita berikan kepada mereka. Nah, dari mereka itulah mereka dapat lebih lagi dari apa yang kita berikan.
Ya. Kalau Pato apa Pato kira-kira sing aplik?
Ya, Pato justru kayak gitu kan, lebih malahan kan.
Nah, biasanya
harusnya lebih ke praktek-praktek itu.
Kan mereka nggak ada koas. Nah, Pato itu
biasanya nggak ada koas kita ya, karena kita nggak ada koas, yang ada koas nggak masalah ya.
Ya, tapi koasnya juga nggak hands on kan, jadi mesti ini harus lebih banyak koordinasi sama luar. Gitu.
Ya itu ya bagusnya gitu, berarti koordinasi sama luar karena nggak hands on itu. Iya.
Untuk nambah-nambah.
Dosen praktisinya banyak Pak tuh. Waktu
Asdos.
ini koas itu.
Asdos lah.
Panggil dosen praktisi.
Ya. Oh ya, dosen ini kalau yang sering Pak Prabada. Yang sudah rutin.
Ya. Apalagi mikro ya, tambah wakeh ya. Mikro ya. Apalagi mikro.
Update ilmu ini ya di luar.
Dalam
mohon maaf. Kalau koas gitu juga manggil dosen praktisi.
Yang setahu saya kok enggak ya?
Itu bisa LVK apa? Gone Ibu Iwan itu?
Puswetma.
Puswetma, ya, Puswetma.
Ya LVK, LVK. Ini Puswetma.
LVK mbiyen.
Iya, Puswetma iso ngajar.
Iki gak pamit-pamit soalnya kangen.
Iya,
lama nggak ketemu.
Dia ke kampus.
Saya kalau sama Bu Uci bola-balik ketemunya pas nguji ya, Bu Uci ya.
Kita harus sering mandi. Kita harus sering mandi sekarang, nggak boleh kemproh ya. Datang baju langsung mandi, nggak boleh makan dulu.
Iya.
Itu protokol.
Nggak boleh pegang apa-apa, Bu.
Langsung.
Nggak boleh pegang apa-apa, langsung ke kamar mandi.
Itu kuncinya itu. Nggak apa-apa kita gaul orang banyak tapi protokol tetap diperhatikan. Gitu.
Normal ini nggak new normal ya Allah.
Terus kita nggak bisa lama-lama. Maksudnya dulu kan 7 sampai malam nggak iso. Pulang dulu balik maneh.
Iya, sampai kapan kampus sepi ya rasanya?
Kalau katanya apa mau Januari nanti offline itu apa masih wacana atau bagaimana ya?
Wacana kalau di UNER itu
wacana ya.
Maret.
Iya.
Maret rencana.
Oh, Maret.
Sudah selesai offline-nya ini sudah selesai.
Kalau ITS iya. Januari ITS, tapi kasusnya tambah banyak gini.
Kita sudah merencanakan, tapi kan kasusnya meningkat kan. Waktu itu kan kasus turun, terus merencanakan offline.
Ya, jangan takut diperiksa.
Kalau dulu, kok dari Kementerian, Menteri Mendikbud, kan Januari sekolah dibuka lagi, sekolah dan kampus dibuka lagi Januari.
Iya. Setelah turun itu kan ya.
Ya, waktu
banyak
yang kuning.
Setelah itu naik lagi lah, Bu. Terus
ya, orang-orang pada bosan sudah di rumah kan, sudah jenuh. Jadi mereka sering pergi sekarang dan tidak memperhatikan protokol kesehatan.
Iya, sering pandemi Indomaret itu nggak pakai masker, ngono. Aduh,
merasa sakti ya, Bu.
Iya, tapi kan lainnya ya opo.
Nah, itu makanya. Bagus.
Orang prosok loh, kali maskernya balik kok
Nah, pemeriksaan gratis, ojo wedi diperiksa. Soalnya tahu awal itu lebih baik daripada nanti kalau kita sudah parah, angel ditulungi. Nek si awal, jadi kita tahu. Jadi pemeriksaan gratis. Aku saiki lebih sering-sering kok. 2 minggu.
Nek vaksin dia apa? Nek vaksin?
Baru aku, ojo takon aku nek iku. Ya pastinya mereka merah putih. Enggak, maksudnya kalau vaksin itu kalau sudah aman kan pasti diberikan kalau sudah bisa diaplikasikan. Enggak mungkin diberikan begitu saja, enggak mungkin lah, mesti.
Kena gratis kok kena gratis.
Ya, siapa yang mau jadi uji coba? Katanya Pak Jokowi mau yang yang jelas yang muda-muda yang dicoba ya.
Tapi sekarang yang muda pun tidak menjamin loh Bu Uci. Kemarin teman saya itu barusan meninggal. Teman saya Teman saya SMA dan karena didiagnosa karena COVID padahal dia nggak ada komorbid apa-apa gitu. Jadi cuman kayak flu biasa terus tiba-tiba sesek mau dibawa ke dokter aja udah nggak ada. Ternyata hasilnya memang positif gitu. Makanya jadi memang sebenarnya
gejalanya
juga.
Gejalanya udah berubah-ubah lagi.
Iya.
Jumlahnya banyak yang kita mungkin terpapar tapi sedikit-sedikit.
Ya mungkin banyak faktor juga.
Makanya mungkin nggak
virusnya.
Nggak usah 1 minggu digangi, kadang online di rumah, besoknya ke kampus, online lagi ke kampus gitu. Karena agar tidak tiap hari memberi kesempatan tubuh kita dulu untuk membentuk kekebalan gitu ya.
Betul.
Ini dulu membentuk kekebalan ditambahi mana gitu. Ya.
Plasma kovalen tuh memang efektif ya Bu Nova ya.
Oh, iya kalau itu.
Dari
apa nih dapatnya?
Angel dari 1.000 orang hanya beberapa saja yang bisa. Yang memenuhi syarat.
Bisa itu memenuhi syarat.
Tapi untuk pengobatan itu loh. efektif bener ya.
Ya nek durung parah. Nek durung parah.
Mungkin ya.
Oh, enggak, tapi sekarang dibanding yang lalu itu ini kok kelihatan sudah maju. Ada yang sudah parah, sudah di ventilator, temen itu sembuh.
Antibiotik dosis tinggi juga, perlu antibiotik karena COVID itu manggil-manggil konco-konco nih. Nek wis kena COVID itu bakteri dari itu ya. Jadi dikasih
individual. Jadi tiap orang itu beda-beda anunya, SOP-nya.
Responnya ya.
Jadi obatnya itu beda-beda. Lumayan kok sudah ini.
Nah, itu siapa jadi anaknya dokter Ira kan meninggal ya, dokter Ira anatomi.
Iya.
Iya kan waktu ibu loro COVID ngeterus rumah sakit, tapi aku nggak ngerti ceritanya.
Dokter Ira Sari Gunawan itu ya?
Baru apa udah lama?
Udah agak lama.
Tapi yang meninggal akhirnya
anaknya. Dokter Iranya pulang ke rumah. Malah sekarang praktek lagi Bu Novo dan nggak pakai masker loh beliau itu kalau mau praktek itu. Dan kayak udah apa ya? Udah katanya udah nggak mau pakai masker gitu, udah pasrah gitu. Sampai kayak gitu.
Ya apa ya? Anaknya komorbid, aku nggak ngerti.
Iya, anaknya memang ini katanya punya apa diabetes.
Oh, iya.
Memang apa ada komorbid.
Nek badan nggak enak, wis gak usah kerja yo. Tidur aja ngono ya. Aku saiki takut, tapi lagi enak rong dino gak turu gak apa-apa. Aku iso gak turu rong dino lho, iso lho.
Ya Allah.
30 jam gak tidur deh.
34 jam enggak tidur. Enggak
mau gelas. Kopinya berapa gelas, Bu?
Kopinya ya pagi, sore. Ya biasa seperti biasa. Tapi Mbak 34 jam enggak tidur. Kok iso ya aku biasanya enggak iso.
Tensinya dikontrol juga loh, tensinya.
Tensinya normal.
Itu passion yang tinggi ya, effort yang tinggi ya berarti.
Ya, tergantung motivasinya.
Biasanya
tapi untuk pekerjaan yang kita nggak suka ya ngantuk.
Setuju itu Bu Hani.
Iya. Jadi kita suka, wah getu terus sampai selesai.
Dengan passion yang tinggi.
Nggak ngopi juga getu ya Bu ya, kuat ya.
Jadi seneng.
Good.
Divisi itu gimana? Udah ada berita baru?
Iya, divisi tadi malam kan di berita.
Apa sudah ada SK-nya?
SK-nya itu bukan SK rektor.
Nah terus kok penghonorannya dari mana?
Jadi departemen ya, di dalam SK-nya di dalam fakultas saja ya.
Iya.
Oh, ya betul lah.
Tapi sudah keluar, SK-nya sudah keluar Bu ya.
Belum, baru
SKDK
gambaran.
Tapi ya perlu pakai kamu kendalikan apa ngatur FKH satu departemen ya, mesti ada divisi lah harus itu. Harusnya memang ada.
Kesejahteraannya dari fakultas berarti Bu Hani, cok khawatir Bu Hani.
Amin.
Harus diperjuangkan juga itu mulai awal ya. Hadok ketok ya dari 22 halaman kemarin yang di lantik itu ketua departemen apa kedokteran hewan cuma satu ya.
Oh gitu ya.
FK departemennya.
Hukum FK FKG diperkecil semua.
FKG di merger.
Klinik nggak bisa di merger klinik.
Yang paling kecil yuk FKH tinggal satu.
Itu benar-benar efisiensi itu. Tapi nggak apa-apa Mas Yo dari siji ya kita ya dosennya itu dari karakter dosennya itu wes.
Kalau mengelola prodi S2 mestinya ya gak apa-apa ya dari departemen misalkan mikro itu kan ada IPKMV, ada vaksin lah mikro. Mestinya kan iso dari departemen dhewe ya Anja. Terus iki apa jenenge IPKMV parasit
iki wong SPM iki kok gak usul sih. Nek kene kan gak ngerti masalah Menang.
Nggak tahu lah gak dijawab. Aku sih guru SPM. Aku guru SK.
Tapi kan paham masalah itu.
Kan niku ono klinik, paraklinik, preklinik. 3.
Iya, harusnya gitu dasar.
Tapi aku gak wani aku. Gak wani.
Jalah.
Klinik, paraklinik, dan preklinik. 3.
Iya, tapi menang ae.
Ya apa urusane sing profesor. Aku durung profesor soalnya. Masalahnya
aku gak ngerti sih.
Masalahnya
ini setuju.
Meneng ae wis lah, manut ae wis gak apa-apa. Kan aku durung profesor soalnya. Iya ya wis pokoknya kan masih sak departemen kan wong FKH ini effortnya bagus sekali kan.
Niat-niat ngono ya.
Bagus bekerja itu lillahi ta'ala kabeh wong FKH iku. Apik kan? Iya. Dibanding kita tuh lillahi.
Oh ya kok ngono ya.
Ya iku pancene orangnya baik-baik kabeh FKH iku.
Iya.
Lah gak apa-apa
dari wong fakultas iku lho, wong FKH calon penghuni surga.
Betul.
Amin.
Aku sering diilokno. Lah bos Mbak sampean niku lho, sampai tuwek. Kekno sing arek cilik-cilik iku lho. Kok apa sih karepe? Soalnya nang anu tuh luar-luar kan nek wis senior gitu kan nggak mau kan ngerjakno sing apa ya, jadi milih-milih gitu loh.
Ya gak oleh ngono lah, kita itu sebagai kan sudah dijanji apapun yang dibebankan pada kita kerjakan semua. Kok buriku rezeki gak berupa uang, kok nang balik sing nang liyane. Banyak sekali ke anak, ke suami, ke keluarga. Nah. Ya.
Oke, terima kasih.
Ya, kita menanam, kita menuai nanti. Ya.
Betul sekali.
Harus bentuk uang, harus bentuk barang ya. Iyalah gitu. Iya, matur nuwun semuanya.
Sami-sami.